Rahim. Today we're going to talk about the second part of the salivary glands disorders lecture. Hopefully, it's going to be a short one and not that tiring. Now, first we're going to talk about necrotizing cyalometaplagia. It's a reactive non-neoplastic inflammatory process. It's in the minor salivary glands and mostly the palate is the most common location. It's unclear origin, but usually vascular infarction, usually smoking is the most common cause, and between 23 to 66 years old is the usual age. Unilateral, bilateral involvement may be present, but not that common. Lesions usually appear as large, 1 to 4 centimeters, painless, sometimes painful, deeply ulcerated, near the junction, or lateral to the palatal midline. Patients may report prodromal flu-like illnesses before the onset of the ulceration. Now, basically, it's due to diminished blood flow to the palate or to the minor salivary glands. This can be due to trauma from the local anesthesia, from smoking, from DM, vascular disease, pressure from edentulous prosthesis. Now, it usually raises concern because it looks like cancerous lesion. It looks like squamous cell carcinoma. Now, usually the management is just caution, just conservative treatment, usually goes away and heals spontaneously without any surgical management about 6 to 10 weeks. Sometimes, if it's because of the looks, we can take a biopsy. Now, it usually looks like pseudoepitheliomatous hyperplasia, looking similar to carcinoma. But to differentiate it from carcinoma, there is lack of pleomorphism. The salivary lobular morphology is present, non-dysplastic appearance, and evidence of residual ductal lumina would be present. So that's how it looks, and that's the histopathology of it. Sjogren's syndrome. It's a multi-system disease. It can be primary or secondary. Primary being without any other connective tissue disease. Secondary with usually rheumatoid arthritis, systemic lupus, and so on. Female predominance 9 to 1, and mean age about 50 years of age. Now, the signs and symptoms. The first complaints from the patients would be arthritic complaints. Ocular symptoms would later follow, salivary gland symptoms would later follow. There will be xerostomia and keratoconjunctivitis or low tears. Now, there is a test called Schimmer's test. The normal is about 15 to millimeter or greater wetting of the paper after 5 minutes. Mild 14 to 9. Moderate 8 to 4, and severe less than 4 millimeters, and that would be most patients. This is Schimmer's test. Basically, this paper should be filled and collecting around 15 millimeters of tears. Now, to diagnose Sjogren's syndrome, we have the criteria. Aside from the patient's complaints, we need to have the criteria. It's divided into symptoms and tests. Symptoms, ocular or oral. Signs, ocular or oral. For the ocular symptoms, patients having dry eyes for more than 3 months with artificial tears 3 times daily and sensation of a foreign body inside. Oral symptoms, dry mouth more than 3 months using salivary gland swellings, liquids to facilitate swallowing, saligogas to increase the salivary flow, and so on. For the ocular signs, Schimmer's test or Rose-Bengal test, dye staining. For the oral, salivary flow less than 0.1 milliliter per minute unstimulated. abnormal parotid cyelogram, or abnormal scintigraphy. With labial salivary gland biopsy being positive, now usually the 6 to 8 minor salivary glands should be taken for Sjogren's syndrome diagnosis. Positive anti-Rho and anti-La or anti-SSA, anti-SSB antibodies. For the management, it's usually symptomatic care, artificial tears, salivary substitutes, cholinergic medications, but usually we don't like them a lot because they have systemic effects. So mostly they try to take some local effects of the medication. Now for the tumors, the most common tumor happens in the parotid gland. About 85 to 90% of tumors appear in the parotid gland. In the submandibular, about 5 to 10%. In the sublingual, rare. Now usually, major salivary glands have benign tumors, not all the time, but the most common. And in minor, usually it's malignant. In the pellet, 55% nearly. Pleomorphic adenoma, the most common benign tumor. 45 years of age and more in males. The parotid could be bilateral, can reach enormous sizes, and slowly growing painless mass. Now the histopathology would show ductal cells and myoepithelial cells. With connective tissue capsule, this prevents its going deeper into tissues. Sometimes incomplete, this would make a higher risk for seeding of the tumor. The treatment involves complete surgical excision, superficial parotidectomy, 5% risk of malignant transformation for carcinoma X pleomorphic adenoma. Warden tumor or papillary cystadenoma lymphomatosum. It usually affects the parotid gland at the tail, more in males and in the sixth decade of life. Smoking, bilateral, slow growing, soft, painless mass. Usually, entrapped salivary epithelial rests within developing lymph nodes. Also, superficial parotidectomy is the management for it. Monomorphic adenoma, it's uncommon in the upper lip. If it's canalicular, if it's basal cell adenoma, would be in the parotid gland. Usually just simple surgical excision. Mucoepidermoid carcinoma, usually it's the most common malignant salivary gland tumor. 10% of major salivary glands, usually the parotid, and 20% of the minor, usually the palate. At any age, more in males. Submucosal may be painful or ulcerated. Intraosseous forms can be seen at the retromolar area and as a multilocular radiolucency in the posterior mandible. Now there are three cell types: mucous cells, epidermoid cells, and intermediate cells. We divide them into higher grade, low grade, middle grade, or intermediate grade. Now, the more epidermoid cells, the more pleomorphism, the higher the grade, the worse the prognosis would be. Now, low grade surgical excision, high grade more aggressive with local radiation therapy sometimes neck dissection if there's lymph node involvement, and so on. The low-grade lesions have a 95% 5-year survival rate, and the high-grade less than 40% survival rate. That's how it looks intraorally. Now, polymorphous low-grade adenocarcinoma, it is the second most common intraoral salivary gland tumor. So most of the time misdiagnosed as adenoid cystic carcinoma, usually at the junction of the hard and soft pellets, more in males. Slowly growing and asymptomatic mass. Usually we would find a lot of different types of cells, ductal epithelial cells, and Indian file pattern. And usually the treatment wide surgical excision, and the recurrence rate is high and has a high rate of perineural invasion. It can invade around the nerves. Adenoid cystic carcinoma looks like the Swiss cheese pattern. The third most common salivary gland malignancy, usually male to female and 3 to 2 more in males, and mean age of 53, 50% in the parotid and the minor in the pellet. It can lead to facial paralysis because of the perineural invasion. Slow growing non ulcerated mass with chronic dull pain. Wide surgical excision by radiotherapy, but poor prognosis. So we've reached the end of the lectures. Hopefully you enjoyed it, and hopefully it was good. You got some information from it. And thank you so much for watching the videos and everything. Thank you.